So hello everyone. Now in this lecture we study regarding aortic regurgitation. So it is a condition where the aortic valve is incompetent. So this is the aortic valve that you can see in the image. It is incompetent. That is, it won't be able to close properly, causing a backflow of blood into the left ventricle instead of going ahead. That is what we see in aortic regurgitation. So we need to understand the causes. So bicuspid aortic valve, it can lead to aortic stenosis also and aortic regurgitation also. A rheumatic heart disease, the valve cuts they become very short. This will cause improper closure of the valve and lead to aortic regurgitation. So if the valve cuts become short, they won't be able to close properly, leading to regurgitation. Infective endocarditis, it damages the valve and leads to aortic regurgitation. Aortic dissection, there is a tear in the inner part of the aorta, and this tear may go up to the aortic valve, can lead to aortic regurgitation. So what is aortic dissection? Tear in the inner part of the aorta, and this tear may go up to the aortic valve and can lead to aortic regurgitation. So now, aortic dissection, usually aortic dissection commonly is associated with hypertension. So aortic dissection is strongly associated with this hypertension because high blood pressure can weaken the aortic valve, making it more susceptible to tearing and dissection. That's why aortic dissection is commonly seen or associated with hypertension. Then Takayasu aortitis, inflammation of the aorta, and this leads to aortic dilatation. And that aortic dilatation will cause the dilatation of the annulus. And this dilatation of the annulus, it can lead to a aortic regurgitation. So if the aorta dilates, the annulus that is attached to it also will spread out. And if that spreads or dilates, the aortic valve won't be able to close properly, causing a regurgitation. Then a myxomatous degeneration of the valve leads to conditions like mitral valve prolapse and aortic regurgitation. Conditions like syphilis and Marfan syndrome, they are associated with aortic regurgitation. So if they ask you a question regarding the cause of aortic regurgitation, you need to understand these causes. Now, clinical features of aortic regurgitation. So, first we'll talk about acute aortic regurgitation. So, what are the causes of this? Like, in infective endocarditis, acute rheumatic fever, acute aortic dissection can lead to a acute aortic regurgitation. So, presentation of acute aortic regurgitation will be such of hypotension along with cardiogenic shock. So, because now the blood from aorta is not going ahead in the body, it is going back into the left ventricle because of regurgitation. So, your patient will present with a hypotension and cardiogenic shock. And due to the regurgitation, the stroke volume, that is the amount of blood going out of the left ventricle, it will be reduced, causing a hypotension and shock, right? In acute aortic regurgitation, the ventricles don't have time to remodel itself to accommodate the blood. So because it's a very acute process, so when the blood is coming back into the ventricles, in this acute phase, the ventricles will not be able to become hypertrophy and accommodate the blood. So that's why in the acute stage, the left ventricle will put the blood back into the left atrium. And from the left atrium, there will be backflow into the pulmonary vessels, leading to a pulmonary edema, causing patient complaints of dyspnea. So in acute aortic regurgitation, there will be dyspnea. Now, patient with acute aortic regurgitation may die within 4 hours because it's an acute representation where there can be cardiogenic shock, dyspnea that I told you. So they can die within 4 hours because the blood from the aorta is not going ahead, it's all coming back. Now, we need to understand chronic aortic regurgitation. It's a slow process with a latency period of 10 to 15 years. So it's a very slow process going over 10 to 15 years. So the initial symptoms can be, uncomfortable sensation, uncomfortable awareness of the heartbeat while lying down. Now, as blood, it will come in the left ventricle slowly over a period of time. There is an increase in chamber size of left ventricle known as a eccentric hypertrophy. So now in chronic aortic regurgitation, the blood is coming in the left ventricle slowly over a period of time. So there is an increase in the chamber size of the left ventricle, and this is known as a eccentric hypertrophy. So the spelling is ECC, not ESS. So eccentric hypertrophy is a type of heart muscle thickening where the heart chambers enlarge and the heart wall thickness is also. So you can see that normally this is the left ventricle chamber and this is the left ventricular muscle. So in eccentric hypertrophy, what happens because of this chronic regurgitation, the heart chamber, the left ventricle chamber size also you can see is enlarging, along with a slight increase in the heart wall thickness. That is a eccentric left ventricle hypertrophy. And the cause of eccentric hypertrophy is always volume overload, because when volume is coming in, the chamber will have to increase its size. So conditions like aortic or mitral regurgitation, myocardial infarction, dilated cardiomyopathy, they come under eccentric hypertrophy. Whereas uh, talking about concentric hypertrophy, see in concentric hypertrophy, the left ventricle chamber size remains same, but the heart wall thickness increases. Then that is concentric hypertrophy. It is seen in conditions of pressure overload like aortic stenosis and chronic hypertension. So very important concept. A concentric hypertrophy and eccentric hypertrophy. In aortic stenosis, there is an increase in the heart muscle size. But the heart cavity remains same. That's why we call it as a concentric hypertrophy in aortic stenosis and eccentric hypertrophy in aortic regurgitation. Very, very, very important. Going to the next concepts now. In aortic regurgitation, the preload and afterload is increased. So they can give a question, all of the following things are seen in aortic regurgitation except preload is increased, afterload is increased. So what is preload, afterload? So they're telling you that in aortic regurgitation, the preload and afterload is increasing. So what is preload? Preload is known as the left ventricular end diastolic pressure. It is the amount of ventricle stretch at the end of diastole. Preload, that is before contraction, what is the preload it is having? So that preload is the ventricle gets that preload during the diastole. So preload is known as the left ventricular end diastolic pressure. That means the pressure in the ventricle at the end of diastole. It is the amount of ventricle stretch at the end of diastole, because by the end of diastole more amount of blood regurgitates into the left ventricle, increasing the stretch of ventricle. So basically, in aortic regurgitation, during diastole, the aortic valve was supposed to be closed. But now during diastole, this aortic valve is open. So more blood is entering the left ventricle. And that's why the preload of left ventricle is increasing in aortic regurgitation. Now, how is afterload increasing in aortic regurgitation? Afterload, it is a systemic vascular resistance. That is the amount of resistance the heart must overcome to open the aortic valve and put blood out into the systemic circulation. That is afterload. So the afterload is nothing but the amount of pressure the ventricle has to apply to put the blood forward into the body. Now during regurgitation, when blood is coming back into the ventricle, so the left ventricle has to put more pressure to put blood into the systemic circulation. That's why afterload is also increased in aortic regurgitation. So for example, if like you want to put water through a pipe, but from the other end also water is coming back to the opening of the pipe. So you have to put more pressure to overcome that other water that is coming towards the opening. That's why a simple line in aortic regurgitation, preload and afterload is increased. We'll talk regarding the Frank-Starling law in aortic regurgitation. The stretching of the myocardial fibers will generate more force of contraction. So now, due to regurgitation, the left ventricle dilates and stretches. So understand this. Because of aortic regurgitation, more blood is coming into the left ventricle. So the left ventricle is going to dilate and stretch. It will now contract more forcefully, because see, it is dilating and stretching. If you take a rubber band and you stretch it and then you leave it, so with more force it will go ahead. So now left ventricle is dilating and stretching, and it will now contract more forcefully, and hence the systolic blood pressure is very high in aortic regurgitation. So I repeat, why is the systolic blood pressure high in aortic regurgitation? Because of regurgitation, blood is coming back into the left ventricle. So the left ventricle is stretching, and then because of that, it goes ahead. Now, diastolic blood pressure normally is produced by the aortic recoil. Okay. Now, but in aortic regurgitation, as most of the blood goes back into the left ventricle, the aortic recoil will be less. So there will be less blood in the vessels. So there will be the aortic vessel will not be stretched, and it won't be able to produce a diastolic pressure because of its recoil. That's why in aortic regurgitation, diastolic blood pressure will be less. So 2 points you understood now. In aortic regurgitation, systolic blood pressure is high, and in aortic regurgitation, diastolic blood pressure is low. Now, patient with aortic regurgitation will have a blood pressure of 200 by 40. That means systolic will be very high and diastolic will be very low. So there's a lot of gap between this systolic and diastolic blood pressure. So this is called as a high pulse pressure or wide pulse pressure. So high pulse pressure or wide pulse pressure is seen in aortic regurgitation. So normally the blood pressure in the lower limb is more than the blood pressure in upper limb because of gravity. Like 140 by 80 can be in lower limb and 120 by 80 can be in upper limb. This difference in blood pressure of lower limb to upper limb is less than 20 mm of Hg normally. So normally the difference of blood pressure in upper and lower limb is less than 20 mm of Hg. But in aortic regurgitation, the blood pressure difference between the lower and upper limb is more than 20 mm of Hg. Now why? Because of this phenomenon, because the systolic is very high and diastolic is very low. So the blood pressure difference between lower and upper limb will be more than 20 mm of Hg in aortic regurgitation. And this difference is called as a Hill sign. So yes, Hill sign is seen in aortic regurgitation. In coarctation of aorta, the blood pressure of upper limb is more than the blood pressure of lower limb. Okay, I repeat myself. In coarctation of aorta, the blood pressure of upper limb is more. So normally blood pressure of lower limb is more than upper limb. But in condition of coarctation of aorta, the blood pressure of upper limb is more than the blood pressure of lower limb. Now why? See, blood pressure is equal to cardiac output into the peripheral resistance. In coarctation of aorta, the resistance is more. So in coarctation of aorta, there is a basic constriction here. So that's why the blood pressure of the upper limb is more than the blood pressure of lower limb. Because of this constriction, there is more resistance in the upper limb. So you can see there is a constriction here. So there will be more resistance here. And whereas less blood is going to the lower limb. So if less blood is going to the lower limbs, so BP will of lower limb will be low. So in coarctation of aorta, the BP of upper limb is more than the BP of lower limb. I hope you have understood this. Now another finding of aortic regurgitation, we have a phenomenon known as collapsing pulse, Corrigan's pulse, water hammer pulse. Now, this condition is characterized by an abrupt, very rapid upstroke of the peripheral pulse, followed by a rapid collapse. So, this is called as whenever you are trying to palpate the pulse, radial pulse, there will be a rapid upstroke and there will be a rapid collapse. So, this phenomena is seen in aortic regurgitation, which is called as collapsing pulse, Corrigan pulse, or water hammer pulse. All are MCQs and these words. Now, it is best appreciated by raising the arm abruptly. So, normally, if you check your radial pulse and then you raise the arm, still the radial pulse will be same. But when you appreciate by raising the arm abruptly and feeling for the radial pulse, as when you lift the arm due to regurgitation, you will feel the collapse in pulse. So, normally, you're checking the radial pulse, and when you lift the arm abruptly, there will be a regurgitation of blood. So, you will not feel that pulse upstroke. They will feel a rapid collapse, and this is called as collapsing pulse, Corrigan's pulse, and water hammer pulse. The patient also complains of angina because in aortic regurgitation, as the blood regurgitates into the left ventricle instead of going in the coronary vessels. So, because blood is going back into the left ventricle, it is not reaching the coronary vessels. There will be a mismatch of demand and supply. So, there will be complaints of angina as well. Now, important signs in aortic regurgitation. Question can come: all of the following signs are present in aortic regurgitation except. So, you must know. Now, Quincke's sign. When pressing the nail bed, there will be initial blanching, that is discoloration, and then it will turn red. This is called as a Quincke's sign. So, what is Quincke's sign? When pressing the nail bed, there will be initial blanching, discoloration, and then it turns red. This is called as Quincke's sign. So, exactly, I'll tell you what's happening in Quincke's sign. So this Quincke's sign, also called as Quincke's pulse, okay, sometimes. It's a clinical finding observed in severe aortic regurgitation. That is also chronic type. So you'll see visible pulsations in the nail bed with a light pressure is applied, and it causes the nail bed to alternately flush and become blanch with each heartbeat because of this whole regurgitation phenomena. Because the blood supply is not a constant, it's a regurgitation coming out. Then Duro's sign. By light compression of the femoral artery with a stethoscope, you will hear a murmur. And again, the reason for this murmur is again the regurgitation. Then Traube's sign, when auscultating the femoral artery, will hear a pistol-like shot, which is the systolic sound produced by rapid distension of artery. So we told you that the left ventricle, it gets hypertrophy. So when it contracts with great force. So this is a Traube's sign that you will hear a pistol-like shot while auscultating the femoral artery. This is Traube's sign. Then Muller's sign, pulsation or bobbing of the uvula, which occurs during systole. It occurs due to increased. So I told you, left ventricle is stretching. It is going to push with great force. So there will be an increased stroke volume, and because of that, there will be a pulsing, bobbing of the uvula because it will receive that kind of stroke volume. This is called as a Muller's sign. Then we have D Musset sign. It's a rhythmic nodding and bobbing of the head, which occurs in syncing with beating of heart. This occurs as the systolic pulse is being felt by the patient because of the increased pulse pressure in aortic regurgitation. There's so much difference between the systolic and diastolic blood pressure that jarring will be felt by the patient because of the increased stroke volume. This is called as a D Musset sign, rhythmic nodding and bobbing of the head, seen in aortic regurgitation. Talking regarding the murmur of aortic regurgitation, aortic regurgitation is a problem of diastole, okay, causing a diastolic murmur. So as the blood regurgitates during diastole due to the turbulence, you'll get an early diastolic murmur. So during diastole, the aortic valve was supposed to be closed, but it is not closing, so the blood is going to come back. And that will create a turbulence, which will produce a early diastolic murmur. Now, during the late phase of this regurgitation, now see initially how much of blood had to come, it comes. Then during the late phase, the blood coming back into a left ventricle reduces. So the intensity of the murmur goes on decreasing. Hence, it's a diastolic decrescendo, that is reducing intensity murmur. So as the blood coming back into the left ventricle reduces, this murmur is called as a diastolic decrescendo murmur. Now, during the middle part of the diastole, the blood will hit the anterior leaflet of mitral valve, producing a mid-diastolic murmur known as Austin-Flint murmur. So during the middle part of diastole, as more blood is coming, the blood will hit the mitral valve anterior leaflet, and that produces a murmur, and this is called as a Austin-Flint murmur. So diastolic decrescendo murmur seen is aortic regurgitation. Austin-Flint murmur also seen in aortic regurgitation. Now, many patients with a pure aortic regurgitation or a combined aortic stenosis with aortic regurgitation, the carotid artery pulse is bispherians. That is a double pulse noticed during systole. So what is this? Pulses bispherians. A pulse with a double beat during systole is often observed in severe aortic regurgitation due to the combined effects of a high stroke volume and the backflow of blood during early diastole. So because of this high stroke volume, backflow of blood, this kind of mismatch will cause a double pulse known as a pulses bispherians, which is seen in aortic regurgitation. Last slide of this lecture. What is the investigation of choice for aortic regurgitation? It is echocardiography. On ECG, you will see left ventricular hypertrophy, obviously. Now, how will you see left ventricular hypertrophy on ECG? I told you in the previous lecture. I'm repeating it in short. To identify the left ventricular hypertrophy, we have to check the height of S wave in V1, and we have to check the height of R wave in V5 or height of R wave in V6. You have to add it. And if it is more than 35 mm, if it is more than 35 mm, it is left ventricular hypertrophy. So easy. And how much is one small square mm and how much is one large square? I've told you in the last lecture. So you can refer that. Easy. And also in aortic regurgitation, you have left axis deviation. So why do you have a left axis deviation? See, left axis deviation on an ECG will indicate that the electrical activity of the heart is shifting to left direction. That means left axis deviation. More electrical activity happening in left direction. This change is often seen in conditions of left ventricular hypertrophy. So the left ventricle has become hypertrophy. That means left ventricle has become more dominant. And that's why the heart's electrical activity will be more in the left ventricle. That's why in aortic regurgitation, we see left axis deviation. Each and every statement was an MCQ. Thank you and do revise.